Welcome. In this session, we'll be discussing about the role of lasers in the management of glaucoma. We'll start with the basics of laser. Laser light, as we know, is monochromatic in the sense that all the waves in a laser beam have the same wavelength, is coherent in the sense that all the laser waves in a laser beam are in phase with each other, is collimated in the sense that all the laser waves in a laser beam move in the same direction with little dispersion, and because of these three properties, lasers are able to deliver a large amount of energy to the target tissue. When a laser machine is switched on, the electrons of the atoms in the laser medium are activated to an excited state either by a flash lamp or by electricity or by another laser. Then these excited electrons fall back to their resting state emitting photons. These emitted photons stimulate excited electrons in other atoms to fall back to their resting state, releasing more photons of similar wavelength. So when the laser is switched on, a large number of atoms become activated with their electrons moving to their excited state. In some of these atoms, the excited electron spontaneously fall back to its resting state, emitting a photon. These photons then stimulate excited electrons in neighboring atoms to fall back to its resting state, thus emitting another photon of similar wavelength. So inside the laser cavity in the laser medium, there is a chain reaction which leads to generation of a large number of photons of the same wavelength. The laser cavity has two mirrors at either end oriented parallel to each other, between which the emitted photons travel back and forth, resulting in a coherent and collimated beam which is allowed to escape through one of the mirrors, which is only partially reflecting. Among the laser tissue interactions, we have thermal interactions and non-thermal interactions. Among the thermal interactions, we have photocoagulation and photovaporization. In photocoagulation, the heat generated by the laser in the target tissue induces inflammation and scarring of the target tissue. And among the glaucoma laser therapies, photocoagulation is used in laser iridoplasty and probably also in trabeculoplasty, but the actual mechanism of action of trabeculoplasty is still uncertain. In photovaporization, absorption of the laser energy in the target tissue results in vaporization of intracellular and extracellular water, and photovaporization is the mechanism by which Argon laser iridotomy creates a perforation in the iris. Among the non-thermal laser tissue interactions, we have photodisruption, in which absorption of the laser energy in the target tissue leads to plasma formation by stripping electrons from atoms, along with generation of a shock wave. And this is the mechanism by which Nd:YAG laser iridotomy creates a perforation in the iris. In a photochemical reaction, the laser energy activates a chemical introduced into the body, and photodynamic therapy following injection of vertiporfin is an example of this mechanism. In photoablation, laser energy results in disruption of the covalent bonds in the target tissue, and this is the mechanism by which the cornea is reshaped by the LASIK procedure. And in plasma-induced ablation, the laser energy causes plasma formation in the target tissue, but with minimal generation of shock waves. And femtosecond laser corneal flap creation utilizes this mechanism. Among the laser treatment options available for the management of glaucoma, we have laser trabeculoplasty, laser peripheral iridotomy, laser iridoplasty, laser pupilloplasty, and cyclodestruction. Laser trabeculoplasty or LTP is indicated in certain open-angle glaucomas, specifically primary open-angle glaucoma, normal tension glaucoma, pseudoexfoliation syndrome, pigment dispersion syndrome, and steroid-induced glaucoma, and this is very important to remember. Laser trabeculoplasty can also be used to treat ocular hypertension patients who require treatment, and as we know, ocular hypertension is open angle in nature by definition. Laser trabeculoplasty is often used as a first-line agent in glaucoma therapy and has been found to be more effective when performed earlier than later in the course of the disease, and is cost-effective as compared to medications. Laser trabeculoplasty is also particularly useful in patients not being able to administer the prescribed anti-glaucoma drugs by themselves, not being able to tolerate these drugs, having poor compliance to the therapeutic regimen, not responding to the drugs, or with significant ocular surface disease in whom drops containing preservatives are relatively contraindicated. Laser trabeculoplasty lowers intraocular pressure by increasing aqueous outflow through the trabecular meshwork following application of laser on the trabecular meshwork. And three methods of laser trabeculoplasty have been described: Argon laser trabeculoplasty or ALT, selective laser trabeculoplasty or SLT, and micropulse laser trabeculoplasty or MLT. Exact mechanism of action of laser trabeculoplasty is yet uncertain, but possible mechanisms include stimulation of cell division, cytokine-mediated alteration in the biomechanical properties of the extracellular matrix of trabecular meshwork and endothelial cells of the Schlemm's canal, and also stimulating phagocytic activity of trabecular meshwork cells, monocytes, and macrophages. Argon laser trabeculoplasty also has been shown to cause shrinkage of collagen fibers and widening of the area between two treatment sites. The contraindications of laser trabeculoplasty include ocular inflammation as found in uveitic and neovascular glaucomas, because laser trabeculoplasty may promote inflammation and formation of peripheral anterior synechia. Laser trabeculoplasty is contraindicated in angle closure glaucomas in which the trabecular meshwork is inaccessible, and laser trabeculoplasty is also contraindicated in certain open-angle glaucomas such as congenital juvenile angle recession and aphakic glaucomas. So there are certain open-angle glaucomas also where laser trabeculoplasty does not work. Laser trabeculoplasty is also contraindicated in patients with very advanced glaucoma and or severely elevated intraocular pressure, because these patients are susceptible to the immediate post-laser intraocular pressure spike which may occur following laser trabeculoplasty. Before laser trabeculoplasty, brimonidine eye drop is instilled 1 hour prior to the procedure and again immediately after the procedure to minimize post-laser intraocular pressure spikes, and if the trabecular meshwork is not properly visible, prior iridoplasty or peripheral laser iridotomy can be done, and we'll be discussing these procedures later in this session. For laser trabeculoplasty, a gonio lens is placed on the eye to visualize the angle, and a mirror of the gonio lens is positioned perpendicular to the aiming beam, with the aiming beam positioned in the center of the mirror. Argon laser trabeculoplasty is performed with an argon laser emitting laser of wavelength 514 nanometers, and the laser is applied at the junction of the anterior non-pigmented and posterior pigmented portions of the trabecular meshwork as shown here in this diagram, and the spot separation between two adjacent applications is kept between 1 to 2 spot diameters. And in one sitting, 180 degrees of the trabecular meshwork is treated with 40 to 50 such shots. 360 degrees treatment of the trabecular meshwork is not done to minimize risk of post-laser intraocular pressure spike and sparing half of the trabecular meshwork for future treatment. Applying laser too far posteriorly should be avoided to lower the risk of peripheral anterior synechia formation, and during laser application it should be remembered that a pigmented Schwalbe's line or the ciliary body band may be mistaken for the trabecular meshwork. The power of the laser is titrated to obtain only a minimal blanching of the treated area or a small bubble formation. In selective laser trabeculoplasty, a frequency doubled Nd:YAG laser is used, emitting laser of wavelength 532 nanometers, and the laser is applied to the trabecular meshwork as shown here in this diagram. And the laser is called selective because it targets only intracellular melanin with minimal damage to the surrounding structures. In one sitting of selective laser trabeculoplasty, 360 degrees of the trabecular meshwork can be treated with 80 to 120 shots. So in contrast to argon laser trabeculoplasty, in which only 180 degrees of trabecular meshwork is treated in one session, in selective laser trabeculoplasty, 360 degrees of the trabecular meshwork is treated in a single sitting. The power of SLT is titrated to just below the level, producing tiny bubbles, and the spot size is larger than that in ALT and is centered on the trabecular meshwork, spanning the entire width of the angle and placed almost confluent with each other. The spot size and the duration in SLT are fixed. Micropulse laser trabeculoplasty is also performed with a frequency doubled Nd:YAG laser emitting laser at wavelength 532 nanometers, and like selective laser trabeculoplasty, MLT also targets intracellular melanin, and like SLT, 360 degrees of the trabecular meshwork can be treated in one session. The difference with SLT is that in SLT, during application of a single spot, the laser emission is continuous, but in MLT, during application of a single spot, the laser has a 15% duty cycle, which means that the laser emission is on only 15% of the time of a single application and is off in the remaining 85% of the application time. And this allows the treated area to cool during the application of each shot, reducing thermal damage to the target and adjacent tissues. ALT and SLT have almost similar efficacy, with 25 to 30% lowering of intraocular pressure from baseline, and maximum IOP lowering occurs after 4 to 6 weeks. But in the long term, the IOP lowering efficacy of LTP declines, with only 50% of treated patients having significant IOP lowering 3 to 5 years after treatment, and only 30% having significant IOP lowering 10 years after treatment. Lasers in glaucoma and ocular hypertension trial showed that SLT as initial management of glaucoma and ocular hypertension is equally effective as compared with medications and is more cost effective also. Positive predictors of efficacy of laser trabeculoplasty includes older age, glaucoma type, presence of a clear cornea, phakic status or presence of a posterior chamber intraocular lens, and in case of Argon laser trabeculoplasty, moderate to marked pigmentation of the trabecular meshwork. But efficacy of selective laser trabeculoplasty has been found to be relatively independent of trabecular meshwork pigmentation. For repeat treatment with laser trabeculoplasty, in case of Argon laser trabeculoplasty, the previously untreated area can be treated, but repeat treatment of a previously treated area is much less efficacious and may have a higher risk of intraocular pressure rise. SLT can be repeated in an area previously treated with SLT, but IOP lowering efficacy of the repeat treatment is less. Complications of laser trabeculoplasty include raised intraocular pressure immediately following the procedure, which can be detrimental for eyes with very advanced glaucoma and is usually detected within 1 hour of the procedure and lasts for 24 hours. It is more common with heavily pigmented eyes, and in these eyes, power of the applied laser beam should be reduced, and the raised intraocular pressure in most cases can be controlled with brimonidine, but some patients may require additional medications. Other complications of laser trabeculoplasty include anterior uveitis, pain, peripheral anterior synechia formation with Argon laser trabeculoplasty, high FEMA, corneal burns, and reactivation of herpetic keratitis. The primary indication of laser peripheral iridotomy or LPI is angle closure from pupillary block, and this is very important to remember. And pupillary block angle closures in which LPI is beneficial include primary angle closure, primary angle closure glaucoma, acute angle closure, and secondary pupillary block angle closure glaucomas. Secondary pupillary block angle closure from uveitis requires multiple and larger iridotomies because iridotomies in these eyes tend to close. This photograph shows LPI done in an eye with an acute angle closure attack. Prophylactic indications of LPI include primary angle closure suspect patients, but there is a controversy whether all primary angle closure suspects require LPI, and an inferior iridotomy should be done in silicone oil filled eyes, because silicone oil has a tendency to block the pupil, and the iridotomy should be located in the inferior quadrant of the iris because iridotomy in the superior quadrant of the iris may be blocked by the silicone oil, which has a tendency to float upwards in erect posture. Diagnostic applications of LPI include malignant glaucoma and plato iris syndrome because unlike as in pupillary block glaucoma, in these entities, LPI is not able to widen a narrow anterior chamber angle. LPI is not effective when peripheral anterior synechia is present 360 degrees all around even if there is pupillary block, and this is very important to remember. And as we have just discussed, LPI is not effective in angle closure from mechanisms other than pupillary block such as in plato iris, anterior pulling and posterior pushing angle closure glaucomas. LPI cannot be done and surgical iridotomy is required when the cornea is hazy, when the anterior chamber is flat, and when the patient is not able to cooperate on the slit lamp for laser treatment. LPI works in pupillary block angle closure glaucoma with forward bowing of the iris by creating a hole in the peripheral iris, which provides an alternative path for the aqueous humor from posterior chamber to the anterior chamber, bypassing the pupillary block, equalizing the pressure in the anterior and posterior chamber, decreasing the forward bowing of the iris, and thus opening the anterior chamber angle. For laser peripheral iridotomy, an ocular hypotensive agent, preferably brimonidine, is administered 1 hour before and immediately after the procedure to prevent post-laser intraocular pressure spike. And in an acute angle closure attack, lowering the intraocular pressure prior to the procedure helps in clearing the cornea, in pilocarpine-induced iris stretching, and in making the patient more cooperative for performing the procedure. Pilocarpine is also administered prior to LPI, and by constricting the pupil, pilocarpine stretches and thins the iris so that the laser can penetrate the iris more easily. And in a thick brown iris, an argon laser pretreatment may be needed in the planned iridotomy site prior to LPI to thin the iris at that site and to reduce the risk of bleeding in patients taking antiplatelets and anticoagulants. The actual perforation of the iris in LPI is more commonly and conveniently done with the Nd:YAG laser, but may also be done with the Argon laser. And an Abraham or a Weiss lens is used, which have a planoconvex button which magnifies the view of the iris, concentrates the laser energy at the treatment site, and also acts as a heat sink to prevent corneal burns. In addition, on the slit lamp, the high magnification setting is used. The iridotomy site is selected on the peripheral iris, and a thin area of the iris is selected, preferably an iris crypt which can be penetrated more easily. And regarding the location of the iridotomy, some prefer superior location between 11 and 1 o'clock, and others prefer the temporal location to avoid ghost images from occurring, which is said to occur when eyelid margin or tear film bisects the iridotomy opening. 2 to 8 millijoules of energy is usually required and is applied repeatedly at the selected site until the iris perforates at that site. The spot duration and spot size of Nd:YAG laser is fixed, and for LPI the focus of the aiming beam and the laser beam should coincide and should not have anteroposterior separation as is required in Nd:YAG laser capsulotomy. Perforation of the iris is followed by a gush of fluid and pigments into the anterior chamber through the iridotomy, and deepening of the anterior chamber will also be detected. Visualization of the lens capsule through the iridotomy is the preferred endpoint, and although transillumination helps in locating an iridotomy, it does not ensure patency of the iridotomy, and this is very important to remember. The ideal diameter of the iridotomy is 100 to 200 micron, and it is seen that larger iridotomies are more efficacious in deepening the anterior chamber as compared to smaller iridotomies. Often two iridotomies are made in the same sitting. LPI with argon laser causes less bleeding and is not effective in light-colored iris. Following LPI, IOP should be checked after 1 hour, and ocular hypotensive should be given if required. Steroids are prescribed for 1 week, and the patient is re-evaluated after 1 to 6 weeks to confirm patency of the iridotomy and widening of the anterior chamber angle. Complications following LPI include inflammation, bleeding which is usually mild and self-limiting and may be stopped by applying pressure with the contact lens, raised intraocular pressure, Dysphotopsias such as glared halos and streaks, which as we have mentioned occurs when the eyelid margin or the tear film bisects the iridotomy, damage to crystalline lens, damage to corneal endothelium and retinal tears. LPI is effective in deepening the anterior chamber angle in eyes with pupillary block, and persistent angle closure with a patent LPI suggests another mechanism of angle closure such as plateau iris and malignant glaucoma. LPI is able to achieve IOP control in 50% of patients with primary angle closure, and the remaining patients with primary angle closure require additional medication or surgery. Most PACG eyes, however, require additional therapy. It has been established that long-term control of intraocular pressure with LPI is inferior compared with cataract extraction. LPI reduces conversion from PACS to PAC, but even without LPI, the conversion rate from PACS to PAC is low, and so there is controversy whether all PACS patients require LPI. LPI has also been shown to reduce conversion from PAC to PACG, but LPI has not been shown to reduce conversion from acute primary angle closure to primary angle closure glaucoma. The most important indication of laser iridoplasty is plateau iris, and this is very important to remember. In plateau iris, there will be a persistent angle closure in spite of the presence of a patent iridotomy. Another indication of laser iridoplasty is to break an attack of acute pupillary block angle closure before laser peripheral iridotomy can be done in eyes with very shallow anterior chamber and or hazy cornea. And for this indication, it has been found to be as effective as medications. In laser iridoplasty, laser burns are placed in the peripheral iris without penetrating the iris, and this causes contraction of collagen fibers and thinning of the peripheral iris, pulling the peripheral iris posteriorly away from the angle recess, thus opening the angle recess. Prior to the procedure, brimonidine and pilocarpine are administered as in laser peripheral iridotomy, and with a green or a diode laser and an Abraham lens, equally spaced burns are placed in the peripheral iris 360 degrees all around, and the power is titrated to obtain iris burn without pigment liberation. Complications of laser iridoplasty include inflammation, raised intraocular pressure, peripheral anterior synechia formation, anisocoria, pupil distortion, and localized iris color changes. Laser pupilloplasty is a rarely performed procedure in which laser burns are created in the iris immediately peripheral to the pupillary margin in order to cause localized contraction of the sphincter pupillae muscle and thus cause localized dilatation or peaking of the pupil. And this is indicated in acute pupillary block angle closure with cloudy cornea in order to break the attack of pupillary block. Indications for cyclodestruction include painful glaucomatous eyes with poor visual potential, and this is very important to remember. Medically uncontrolled glaucoma in elderly patients not suitable for or who does not want to undergo surgery, and medically uncontrolled glaucoma in patients on anticoagulant therapy in whom the risk of a surgical procedure is significantly increased. Cyclodestructive procedures reduce aqueous production by damaging or destroying the non-pigmented ciliary epithelium. And we have two types of cyclophotocoagulation procedures: transcleral cyclophotocoagulation or TCP and endocyclophotocoagulation or ECP. TCP destroys the entire pars plicatum portion of the ciliary body along with its vasculature and ciliary processes, whereas ECP destroys only the epithelium and the stroma of the ciliary processes, sparing the ciliary body muscle. And this is why, as we shall see, ECP causes much less complications than TCP. Apart from reducing aqueous production, cyclodestructive procedures may lower intraocular pressure by also increasing uveoscleral outflow. And cyclocryotherapy is no longer preferred because of an even higher risk of complications as compared to TCP or ECP. Cyclodestruction usually requires local anesthesia, but ECP can be done under combined topical and intracameral anesthesia. Transcleral or external TCP can be done in two ways: in discrete or continuous wave TCP method, which is the most commonly available cyclophotocoagulation method, Multiple separate applications are delivered with the laser probe in the pedilimbal area circumferentially. While in the continuous or micropulse TCP method, the laser probe is moved in the pedilimbal area circumferentially while continuously maintaining contact with the ocular surface at the area being treated. In discrete or continuous wave TCP, a 810 nanometer diode laser is used and a probe called the G probe is positioned adjacent to the limbus as shown here in this photograph. When the G probe is appropriately positioned adjacent to the limbus, the laser probe as seen here delivers the laser 1.2 mm behind the limbus and thus focuses the laser at the level of the ciliary processes. And 16 to 20 discrete applications are made 360 degrees around the limbus. In continuous or micropulse TCP method, an 810 nanometer diode laser with 31.3% duty cycle, that is having sequential on periods and off periods of 0.5 millisecond and 1.1 millisecond respectively, is applied by continuously sweeping the probe in the pedilimbal area circumferentially around 360 degrees. With both the discrete and the continuous TCP methods, energy should be titrated just below the level at which audible pops are heard, and the 3 and 9 o'clock position should be avoided to prevent damage to the long posterior ciliary nerves and vessels. Endoscopic or internal cyclophotocoagulation, also called ECP, as shown here in this diagram, is often combined with cataract extraction and is called ECP+. ECP can be done with two approaches: a clear corneal approach as shown in this diagram, in which viscoelastic is injected between the iris and the crystalline lens to widen the ciliary sulcus, and then an endoscope is positioned in the ciliary sulcus to directly view the ciliary processes. ECP can also be done through a pars plana route, but following or along with a complete vitrectomy. In endoscopic cyclophotocoagulation, discrete diode laser applications are imparted to the ciliary epithelium 270 to 360 degrees all around. Energy delivered is titrated to obtain whitening or shrinking of the ciliary processes without rupturing the tissue. So ECP prevents overtreatment and minimizes side effects by allowing titration of the energy delivered and selective ablation of the target tissue, which are the ciliary processes as seen here in this photograph. And in this photograph we also see the margin of the optic of the intraocular lens. Through an anterior approach, all visible ciliary processes are treated, as there is a posterior row of ciliary processes which are not visible through the anterior approach, and the treatment effect depends on the amount of energy delivered and distance of the probe from the target tissue. 2 incisions will be required to treat 360 degrees of the ciliary epithelium. Following cyclophotocoagulation, steroids and cycloplegics are administered, and ocular hypotensive medications are continued and slowly tapered as the IOP lowering effect of cyclophotocoagulation sets in. But prostaglandin analogs and miotics should be avoided because they may promote post-laser inflammation. Discrete and continuous TCP have similar efficacy, and 60 to 80% of treated patients achieve intraocular pressure less than 22 millimeters of mercury. Maximal IOP reduction following cyclophotocoagulation occurs after 1 month of treatment. Cyclophotocoagulation may need to be repeated as intraocular pressure lowering efficacy of cyclophotocoagulation decreases over time. Cyclocryotherapy is no longer used unless lasers are not available because the complication rates are higher and more unacceptable. The procedure of cyclocryotherapy is described here and will not go into the detail. Complications of cyclodestruction include pain and inflammation, further loss of vision, cystoid macular edema, and the most important and serious are prolonged hypotony and phthisis bulbi, which are important to remember. As we have mentioned, all these complications are less common and less severe with discrete TCP as compared to cyclocryotherapy, and as compared to discrete TCP, these complications are even less common with micropulse TCP and ECP. Other complications of cyclodestructive procedures include vitreous hemorrhage, and sympathetic ophthalmia. And to avoid this risk of sympathetic ophthalmia, many prefer to treat painful glaucomatous eyes with no light perception with steroids and cycloplegics, and opt for cyclophotocoagulation in these eyes only if steroids and cycloplegics are not able to provide adequate comfort. Endoscopic cyclophotocoagulation can be associated with damage to crystalline lens and zonules, retinal detachment, and endophthalmitis. Laser trabeculoplasty lowers intraocular pressure by increasing aqueous outflow through the trabecular meshwork and is effective only in certain open-angle glaucomas such as primary open-angle glaucoma, normal tension glaucoma, pseudoexfoliation syndrome, pigment dispersion syndrome, and ocular hypertension. It can be used as a first-line therapy or can be used in patients in whom medical therapy is not effective or is not tolerated. Contraindications to laser trabeculoplasty include ocular inflammation, angle closure glaucomas, and in patients with very advanced glaucoma and or very high intraocular pressure. In Argon laser trabeculoplasty or ALT, a diode laser is used to treat the junction of the anterior non-pigmented and posterior pigmented portion of the trabecular meshwork. In selective laser trabeculoplasty, a frequency doubled Nd:YAG laser is used to treat the entire thickness of the pigmented portion of the trabecular meshwork. Both are equally effective with 25 to 30% IOP lowering from baseline, with the maximal effect occurring 4 to 6 weeks following treatment. But the IOP lowering efficacy of laser trabeculoplasty declines after several years. Complications of laser trabeculoplasty include post-laser intraocular pressure spikes, anterior uveitis, and with ALT, peripheral anterior synechia formation. SLT can be repeated in a previously treated eye, but repeat ALT is not effective. Laser peripheral iridotomy is indicated in pupillary block, angle closure glaucoma, silicone oil-filled eyes, and to diagnose malignant glaucoma and plateau iris syndrome. It is not effective in eyes with 360 degrees peripheral anterior synechia, even if there is pupillary block. It is usually done with an Nd:YAG laser but can also be performed with an Argon laser. Argon laser can also be applied at the planned iridotomy site before perforating the iris with the Nd:YAG laser, which is useful to thin a thick brown iris and also to reduce bleeding. Prior to laser peripheral iridotomy, brimonidine and pilocarpine are administered. An Abraham lens with a planoconvex button is placed on the eye and a thin site on the peripheral iris in the superior or temporal location is selected. Perforation of the iris is indicated by a gush of pigment and fluid in the anterior chamber and deepening of the anterior chamber. Patency of the iridotomy site can be confirmed by visualization of the capsule of the crystalline lens through the iridotomy. Transillumination through the iridotomy does not confirm patency. Complications of laser peripheral iridotomy include inflammation, post-laser intraocular pressure spike, bleeding, dysphotopsia, damage to the crystalline lens, and retinal tears. Laser peripheral iridoplasty is the application of laser burns on peripheral iris which contracts the treated area of iris. Laser peripheral iridoplasty is indicated in plateau iris syndrome and also to break an attack of acute pupillary block angle closure in an eye with cloudy cornea through which laser peripheral iridotomy is not possible. Cyclodestruction lowers intraocular pressure by reducing aqueous humor production by destroying the ciliary epithelium. Increase of uveoscleral outflow may also contribute to IOP lowering by cyclodestruction. Cyclodestruction can be performed with either cryo or with a diode laser. Cyclocryotherapy is no longer preferred because of high incidence of postoperative complications. Cyclophotocoagulation is done with a diode laser and can be performed transclerally when it is called TCP or endoscopically when it is called ECP. TCP is done with a G probe which focuses the laser to the ciliary processes. During TCP, the 3 and 9 o'clock position should be avoided to prevent injury to the posterior ciliary nerves and blood vessels. In ECP, the ciliary processes are directly visualized and coagulated. Complications of cyclodestruction include pain, inflammation, cystoid macular edema, hypotony and phthisis bulbi. They are most common and severe with cyclocryotherapy and least common with ECP. Thank you for listening.